Welcome to the Deep Dive. We're here to sift through the latest research, the consensus reports, and really pull out those critical insights you need to stay informed. Today, we're taking a very focused deep dive into congenital cytomegalovirus infection, CCMV, and this exploration is specifically shaped for you, the students of DIU de Medicine Fetal. We want to give you a clear, concise, but really comprehensive understanding of this complex area, highlighting what's truly practical for your clinical work.
Absolutely. We've gathered quite a bit recent studies, some key clinical trial results, and latest consensus recommendations to really guide our discussion today. Our mission really is to dissect the current understanding of CCMV. We'll look at its prevalence, its impact, and the evolving strategies for diagnosis, prevention, and long-term management. The goal is ensuring you grasp the nuances that actually inform best practice out there.
Okay, so let's embark on this. We'll examine the profound burden of CCMV, the complexities of diagnoses both before and after birth, those emerging preventative measures, and how we manage the impact on affected newborns. Our focus is really on distilling the actionable knowledge from all these sources for you. Right, so to really get a handle on the challenge CCMV presents, let's start with the basics. Just how significant is this infection compared to other congenital conditions?
Well, that's something that's often, I think, underestimated, the sheer scale. While the percentage might sound small, roughly 0.64% to 0.7% of all newborns globally.
Still sounds like a lot when you think about total birth.
Exactly. It translates to a massive public health burden. And importantly, it stands as the most common non-genetic cause of neurodevelopmental delay and sensorineural hearing impairment. That fact alone really underscores its profound significance in fetal medicine.
And when we talk about its long-term impact, what does that actually look like for these children? What kind of outcomes are we dealing with?
So the numbers suggest around 15 to 20% of those infected will, unfortunately, suffer from permanent sequelae. We generally group these into mild, they may be isolated unilateral hearing loss, some vestibular disorders, and severe. And severe can encompass bilateral hearing loss, significant neurological issues like intellectual disability, epilepsy, even cerebral palsy. The spectrum is quite wide.
Which makes early identification so critical, right?
Absolutely. And understanding the transmission dynamics is vital here, too. We often hear about primary and non-primary maternal infections. Can you clarify that distinction?
No way.
Why is it so important prognostically?
Yes, that's a key point. A primary maternal infection means it's a brand new infection acquired during the pregnancy. Non-primary is either a reactivation of a latent virus the mother already had, or it could be a reinfection with a different CMV strain.
And this distinction isn't just academic. It's clinically decisive. The risk of major fetal sequelae, the severe outcomes we just talked about, is almost exclusively linked to a maternal primary infection, and specifically one acquired in the first trimester of pregnancy. That's the critical window. It really dictates our level of vigilance.
Wow. Okay. So the timing, specifically first trimester primary infection, is paramount. Does this difference in infection type also mean different rates of transmission to the fetus?
Yes, it certainly does.
Mm,
For those primary infections, the vertical transmission rate, mother to fetus, is significantly higher, around 32%.
32%.
Whereas for non-primary infections, it's far lower. The estimates are probably less than 3.5%. Now, interestingly, in areas where CMV prevalence is high, non-primary infections actually account for the majority of infected newborns. But, and this is the crucial part we keep coming back to, the risk of severe outcomes for the baby remains primarily tied to that first trimester primary infection.
Which really emphasizes where our diagnostic efforts need to be focused, especially early on. So, given that the first trimester is such a critical window, how do we effectively diagnose maternal infection as early as possible? What's our first line of defense?
Right. The cornerstone, the absolute essential first step, is maternal CMV serology, testing for antibodies. And this needs to be done as early as possible in that first trimester. It involves testing for both IgG and IgM antibodies.
Okay, IgG and IgM.
And for women who are initially seronegative, meaning they don't have these antibodies, the recommendation is for repeat testing, perhaps every 4 weeks until about 14 to 16 weeks gestation, to catch any seroconversion, any new infection.
Right. But what if the initial test comes back with both IgG and IgM positive? That suggests a recent infection, but how do we pinpoint the timing more accurately, which we know is so critical?
Yes. That's where IgG avidity testing becomes indispensable. It helps us differentiate between a recent and a past infection. If we find high avidity IgG in the first trimester, that strongly suggests it's a past infection. It makes a recent primary infection, say, within the last 90 days, highly unlikely.
Okay, so high avidity is reassuring in the first trimester.
Generally, yes. Conversely, low or intermediate avidity points much more strongly towards a recent primary infection. This avidity testing allows us to sort of date the infection with more precision, which, as you said, is fundamental for guiding the next steps and assessing the actual risk to the fetus.
What about using PCR testing, say in maternal blood or urine? Can that help us date the infection?
That's a good question. While CMV PCR and maternal blood or urine can be useful to confirm an ongoing primary infection in certain specific scenarios, maybe if you have an isolated positive IgM result, for example,
Right.
it's generally not considered reliable for precisely dating the timing of that primary infection. Its utility is more about confirming active viral replication at that moment, rather than establishing the timeline, which is so critical for assessing the fetal risk from first trimester exposure.
Okay, that clarifies the maternal diagnosis pathway. Let's pivot then to prevention. Since a vaccine isn't widely available yet, what practical steps can be taken?
Well, primary prevention really revolves around hygienic measures. Simple stuff, but effective. The main risk factor for a woman getting a primary CMV infection during pregnancy is contact with young children, especially kids under 2 years old,
Why them specifically?
because they can shed the virus in their urine and saliva for really extended periods, sometimes months or even years, often without any symptoms themselves. So advising all pregnant women on basic hygiene, meticulous hand washing after changing diapers, after feeding young children, avoiding sharing utensils or cups can significantly reduce this transmission risk. It's about empowering expectant mothers with this practical knowledge.
Simple but potentially very impactful advice. Now, beyond hygiene, what about medical interventions? There's been a lot of buzz around valiciclovir recently. How has the evidence shaped up there?
Yes, the valiciclovir data, I think, represents a truly significant advancement. We now have results from randomized controlled trials, good quality evidence, and these trials have robustly demonstrated the efficacy of oral valiciclovir, specifically at a high dose, 8 grams per day.
8 grams, okay.
Yes, for maternal primary infection acquired either periconceptionally or in that crucial first trimester. And the effect isn't trivial. It can reduce the rate of vertical CMV transmission by as much as 70 to 71%.
70%, that's huge.
It is. It's a major reduction. And the data also suggests the earlier the treatment starts after infection, the more profound its protective effect. This really is changing our approach to primary prevention in those high-risk cases.
That's a game changer. But with such a high dose, are there concerns? Any notable side effects clinicians and patients need to be aware of?
It's generally well tolerated, but yes, some side effects can occur. Things like nausea, headache are relatively common. More rarely, acute renal failure can happen.
Renal failure, that sounds serious.
It does, but it's typically reversible upon stopping the drug. And to minimize this risk, the current recommendation is actually to administer that 8-gram total daily dose as 2 grams 4 times a day. Spreading it out seems to help manage potential renal side effects. So the powerful tool, yes, but like any medication, it needs careful administration and monitoring.
Okay, good to know. And what about the other intervention we used to hear about? Hyperimmune globulin, or HIG. What's the current verdict on that for preventing transmission?
The evidence there is, well, much less encouraging. We have 2 large, well-conducted randomized controlled trials, and they definitively concluded that the standard dose used 100 IU per kilogram every 4 weeks was not effective in preventing vertical transmission.
So standard dose HIG is out?
Based on that evidence, yes. Now, there's some suggestion that higher doses, maybe 200 IU per kilogram every 2 weeks, specifically for very recent first trimester infections, might be considered in certain contexts.
Right.
But the robust evidence supporting its widespread use for prevention just isn't there like it is for valiciclovir now.
Understood. Looking further ahead then, what about a vaccine? Is that still the ultimate goal?
Oh, absolutely. Vaccine candidates are a huge priority. They're progressing through clinical trials. That would arguably be the ultimate preventative solution, tackling this at a population level. However, realistically, it's likely to be several more years before we have a licensed CMV vaccine widely available for general use. It remains a beacon of hope, but not an immediate solution.
Right. So let's assume maternal primary infection is confirmed in that first trimester. Our attention then shifts squarely to the fetus. What's the gold standard for actually diagnosing fetal CMV infection, and what's the optimal timing?
The undisputed gold standard for diagnosing fetal infection is CMV PCR performed on amniotic fluid. And that fluid is collected via amniocentesis. Now, the timing is critical here. Two things to remember. The procedure should be performed at or after 17 weeks gestation.
Not before 17 weeks.
Correct. And perhaps even more importantly, it needs to be at least 8 weeks after the estimated time of the maternal primary infection.
8 weeks after maternal infection. Why that delay?
That delay is crucial to allow for sufficient viral replication and shedding into the amniotic fluid. If you do the amniocentesis too early after maternal infection, you risk a false negative result because the virus hasn't reached detectable levels in the fluid yet.
Got it. So 17 weeks gestation minimum and at least 8 weeks post-maternal infection. And if that timely amniocentesis comes back negative for CMV PCR, how much confidence can we have? Does it rule out future problems?
A negative CMV PCR in amniotic fluid, when it's performed correctly according to those timing guidelines, offers really strong reassurance about the absence of long-term sequelae. While it's theoretically possible for a very late fetal infection to occur after the amnio, these later infections are generally not associated with clinically relevant consequences or permanent deficits. So yes, it provides a very high negative predictive value for serious outcomes. It's a very reassuring result.
Okay. Are there any earlier options being explored? What about chorionic villus sampling, CVS? Can that play a role?
CVS is an interesting sort of emerging area for CMV. You can do PCR on the chorionic villi to look for placental infection. This is typically done earlier, maybe 11 to 14 weeks, following a first trimester maternal primary infection. The data suggests it has high specificity and a strong negative predictive value for ruling out severe CMV-related embryopathy, the kind that leads to major neurological and sensorineural deficits.
So a negative CVS is good news early on.
It is, but there's a caveat. Its sensitivity is lower than amniocentesis for detecting overall fetal infection. This means a negative CVS doesn't definitively rule out a later fetal infection. Often an amniocentesis would still be recommended later in pregnancy to get the final word on the fetal status. Not quite a replacement for amnio yet.
Right, makes sense. Let's switch gears to prenatal imaging. Many people, maybe even some clinicians, might intuitively think that the routine detailed ultrasound scans we do are a reliable way to screen for congenital CMV. What does the evidence actually show?
Yeah, this is a really crucial point, and the evidence is quite sobering, actually. Routine, detailed ultrasound exams, the ones typically done around 20, 24 weeks and maybe 30, 34 weeks, are not an appropriate screening tool for picking up those cases of congenital CMV infection that eventually lead to long-term sequelae.
Not appropriate. Why not?
Well, the studies we reviewed showed that routine ultrasound identified only about 26% of infected fetuses that ultimately developed severe long-term problems. And this was, even though retrospectively, non-specific findings that could be related to infection had been noted in maybe 64% of those cases, but they often weren't specific enough to actually raise suspicion for CMV at the time. So it simply isn't sensitive enough as an initial screening method. It misses too many significant cases.
Wow, only 26% identification of severe cases on routine scan. That's a major limitation. So if routine ultrasound isn't the right tool for screening, what is the role of ultrasound and perhaps MRI when we do know or strongly suspect fetal infection?
Exactly. The role changes completely. In contrast to screening, targeted prenatal imaging, performed specifically because fetal infection is known or highly suspected, demonstrates much higher diagnostic performance. We're talking a sensitivity of around 91% for predicting any long-term sequelae, and importantly, 100% sensitivity for predicting the severe long-term sequelae.
Okay, so targeted imaging is much better. What kind of findings are we looking for?
Common findings on ultrasound that might raise suspicion include things like the fetus being small for gestational age,
Yeah.
SGA, microcephaly, ventriculomegaly, maybe hyperechogenic bowel or placentalomegaly. But the challenge is many of these findings are nonspecific. They could be caused by other things too.
Right, and that's where MRI comes in.
Precisely. Fetal cerebral MRI, usually performed between 28 and 34 weeks, acts as a crucial supplementary tool. MRI is particularly good at identifying subtle but significant brain pathology that might be missed by ultrasound alone, especially things like white matter abnormalities or cortical malformations.
Right back.
The combination is powerful. A normal targeted ultrasound and a normal fetal MRI together offer a negative predictive value close to 100% for moderate to severe sequelae.
That's very reassuring.
It is, although we have to remember there's still a residual risk, maybe around 17%, of isolated unilateral sensorineural hearing loss even with normal imaging. perfect prediction isn't quite possible yet.
Understood. So, moving past the prenatal phase into postnatal care, what are the most common and impactful long-term outcomes we actually see in children affected by CCMV, especially those unfortunate enough to be infected in that first trimester?
Well, the most prevalent long-term issue is definitely sensorineural hearing loss, SNHL. And it's tricky because it can be progressive, meaning it can worsen over time. It can be unilateral or bilateral. And sometimes it doesn't even manifest until later in childhood, which really underscores why we need long-term audiological follow-up for these kids.
So, hearing loss is number one. What else?
Beyond hearing, the neurological issues are significant. This includes psychomotor delay, intellectual disability, epilepsy, and there's also growing evidence suggesting higher incidence of things like autism spectrum disorder and attention deficit hyperactivity problems, again, particularly linked to those first trimester infections. The impact can really be quite broad, affecting multiple developmental areas.
Okay, so how do we actually confirm the diagnosis of CCMV after birth? And when should we be testing
The
newborns?
standard way to diagnose neonatal infection is using CMV PCR on either a urine or a saliva sample. And critically, this sample needs to be collected within the first 3 weeks of life.
Why within 3 weeks?
Because after about 3 weeks, it becomes difficult to distinguish a congenital infection, acquired before birth, from a postnatal infection, acquired after birth, which usually has far fewer consequences.
Yeah.
And one practical point. If you get positive saliva PCR, it's generally recommended to confirm it with a urine sample. This helps rule out potential contamination, say from CMV, in breast milk if the mother is shedding.
Good tip. And who should be tested? Which babies?
Testing is definitely recommended for all infants born to mothers where there was a suspected or confirmed primary CMV infection during the pregnancy. That's a clear indication. Also, any newborn who shows abnormalities on their fetal imaging or presents with certain clinical signs at birth, things like petechiae, an enlarged liver or spleen, hepatosplenomegaly, jaundice, microcephaly, or low platelets, thrombocytopenia. And importantly, isolated sensorineural hearing loss identified on newborn hearing screening is also a very strong indication to test for CCMV. And once you have that diagnosis, a really comprehensive investigation is needed. It's not just about confirming the virus. It involves a thorough physical exam, a panel of blood tests, detailed eye exams by an ophthalmologist, thorough hearing tests, and often a brain MRI, especially if the baby has symptoms or if the cranial ultrasound done after birth shows abnormalities. This multi-system evaluation is crucial to understand the full extent of the infection's impact on that individual child.
That makes sense. It's about assessing the damage. So finally, is there effective treatment for these affected newborns, and what are we actually trying to achieve with the treatment?
Yes, there is treatment available. Antiviral medication, usually valganciclovir given orally, is the mainstay. In more severe cases, particularly if the baby can't take oral medication, ganciclovir can be given intravenously. This treatment is recommended for newborns who have significant CMV-related symptoms at birth, the ones we just listed, or even if they only have isolated sensorineural hearing loss confirmed to be due to CCMV.
And when should treatment start? How long does it last?
Critically, treatment should ideally start as soon as possible after diagnosis, and definitely before the baby is 1 month old. The standard duration of treatment is now 6 months.
6 months of antivirals. What's the goal? Can it reverse damage?
That's an important point. The treatment doesn't reverse established lesions. It can't undo damage that's already occurred, particularly in the brain. But what it does is significantly reduce the viral load. This helps prevent further damage, especially to hearing, and seems to lead to better overall outcomes in terms of both hearing preservation and neurodevelopmental progress down the line. So it's a vital intervention to mitigate the long-term impact as much as possible.
Okay, we've covered a huge amount of ground, from diagnosis to management. Thinking about clinical practice guidelines now, how consistent are they across different regions or organizations? Are we seeing a global consensus emerge on how to handle CCMV, or is there still quite a bit of variation?
There's definitely a clear trend towards greater consensus, which is good news, particularly on the core diagnostic criteria for primary maternal CMV infection, and also on the role of amniotic fluid PCR. Everyone pretty much agrees that's the gold standard for confirming fetal infection. However, heterogeneity or variation definitely still exists.
Where do we see the most variation?
It's most apparent in the sort of procedural details. For example, the precise timing recommended for amniocentesis can vary slightly. Also, the exact protocols for fetal surveillance, like how often and exactly when to do ultrasound and MRI follow-ups if infection is confirmed, aren't universally standardized. These differences often reflect local expertise, resource availability, maybe historical practices, but they do highlight areas where more harmonization could potentially benefit patients and clinicians.
And what about on the treatment front? Especially thinking about treating the mother during pregnancy with valacyclovir, which you mentioned earlier. Have recommendations evolved significantly there in recent guidelines?
Yes. This is probably where we've seen the most dramatic evolution, actually. If you look at older guidelines, say from 5 or 10 years ago, they often hesitated to recommend antiviral treatment for the mother outside of specific research settings. There wasn't enough evidence. But really influenced by the strong data from those recent clinical trials we discussed, the more current guidelines, especially those published since around 2022, 2023, are increasingly advising the prompt administration of high-dose valacyclovir for confirmed maternal primary infection in the first trimester. It really reflects a paradigm shift towards more proactive management during pregnancy itself.
That's a significant shift. So, despite all this progress and increasing consensus, what major gaps or maybe unresolved questions still exist? Areas where the guidelines are maybe less clear or where our understanding needs more work?
Yeah, several areas still need better clarity. For instance, the optimal management of non-primary maternal infection isn't as well addressed. We know sequelae can happen, even if less often or less severely than with primary infection, but guidance is thinner there. We also lack really clear protocols for what to do if you strongly suspect fetal infection based on imaging, but maybe amniocentesis wasn't done or wasn't conclusive. How do you manage that fetus? And another persistent challenge is that issue of routine ultrasound as a screening tool. As we discussed, it frequently misses cases that later develop severe problems.
Which brings us back to the importance of awareness, doesn't it?
It really does. And this raises a critical point that came through the sources. The diagnostic performance of prenatal ultrasound improves dramatically when the sonographer is specifically looking for signs of CMV because they know there's a risk. And crucially, when they know the maternal serological status from the first trimester. So it seems that increasing awareness about CMV among all antenatal care providers, not just specialists, and potentially moving towards more widespread, perhaps even universal first trimester maternal serology screening. These could be key future directions. They seem essential for improving the early identification of those severe cases where timely intervention could make the biggest difference. That kind of systemic change could be really impactful.
This has been a genuinely illuminating deep dive into congenital cytomegalovirus.
Right.
We've really journeyed from its global burden right through to the real nitty-gritty of diagnosis and the fast-evolving landscape of prevention and treatment.
Absolutely. We've seen just how pivotal that early diagnosis in the first trimester is, the quite remarkable potential of valacyclovir now, and the absolutely vital role of targeted imaging and comprehensive postnatal follow-up. It's clear that while huge progress has been made, continuous education, refining our clinical practices based on new evidence, and ongoing research are all still essential.
Yeah, the pace of change, the way evidence is accumulating and actively shaping recommendations in this field, it's quite remarkable to see. So, considering everything we've unpacked today, the challenges that remain, the breakthroughs like valacyclovir, the gaps in guidelines, what do you believe, thinking as future fetal medicine specialists yourselves, is the single most impactful, actionable change? What one thing, if implemented universally, could significantly improve outcomes for congenital CMV? We'll leave you with that thought to ponder.